Restart?
Yeah, I think. Okay, try again now.
Okay, we are back. Sorry for the technical difficulties. Welcome to the wild world of broadcasting to 4 different platforms. So, welcome back to Fertility Fact or Fiction, the best weekly show on the web where we discuss a hot topic, reveal all the truths, dispel all the myths, and then answer all your questions live. So thank you for joining us again. And we've got a great topic tonight, which is really interesting for me because I'm not a believer in PGT for everyone. And this was an amazing study looking at whether or not you could predict embryo survival and live birth from just the characteristics of the embryo in a very large number of cycles and embryos. So very interesting study and really interesting for us to have a look at. So hopefully everybody's just jumping back on and we'll have a chance to review everything. Tarek's heart rate's going to slow back down to normal again and we can go from there. So I hope you've all been doing well. By now, many of you have probably been getting vaccinated. Some of you may have heard that the AstraZeneca virus is being kind of put on hold in some countries because out of 17 million doses, 3 people had blood clots. So I think that that's a little bit of an odd thing to stop an entire vaccine from being used for. The background rate of having a spontaneous blood clot is higher than 3 in 17 million. So it is unlikely that those are related to the vaccine. Nevertheless, who knows, they're going to see what happens with those. I should correct something I said in the last show, which I did not know about, but I've subsequently learned. So I had heard earlier that the AstraZeneca virus was actually either a live attenuated or a killed form of the virus itself. It is not. It is a cDNA virus, which means complementary DNA built from the RNA of the spike protein. And it actually goes into the nucleus of your cell in order to teach your cell to produce the RNA that then produces the protein, which then your immune system responds to. So it is actually quite different from the Moderna and the Pfizer vaccines. And no one really knows what the long-term effects of this cDNA virus are. So while I am totally an avid supporter of the Moderna and the Pfizer, we don't know enough yet about the AstraZeneca. So it should be interesting to find out where the data from that goes, but nobody knows for sure yet. So, okay, so we'll get started on our show now. So the question was, which pre-vitrification parameters are the most predictive of survival and live birth in vitrified, warmed blastocyst transfer cycles? So let's just talk about what that title means. So they wanted to look at which parameters of your embryo are important prior to the freezing of the embryo exclusively using vitrification. Now, most centers should be using vitrification because it's far safer and has much better results than slow freezing. But they have to use pre-vitrification or vitrification. And then they wanted to look at which of those parameters could predict survival of the embryo from the thaw and then live birth after implantation. And so this was a study from IVI, which is that great big group we've mentioned before on the show in Spain. And they have a huge, huge program there. So the study included 11,936 embryos. And they didn't do PGT on any of these particular cycles. So these are all factors that are going to predict the outcome without having the PGT, which is important because for those of us that don't believe in doing PGT for young patients, you still want to be able to give them advice and guidance as to what the chances are without necessarily having the PGT in place. So the things they looked at were the day of vitrification, and it had to be day 5 or day 6. They did not use any day 7s. They looked at the degree of blastocyst expansion. We're going to pop up a picture for you. Can you do that image? Do you have that?
I have that.
So we'll show you an image which if you look from A to B to C to D, you'll see differences in the embryo. So the first one is just the blastocyst. The next one is an expanded blastocyst. The next one is a hatching blastocyst, meaning part of it is coming out of its shell. And then the last one is an actually hatched blastocyst. Is it up there? Yeah. ABCD. So they looked at that, and then they looked at the trophectoderm, which is the portion of the embryo that is becoming the placenta, versus the inner cell mass, which is the portion of the embryo that's becoming the actual baby. And they compared all of that looking at survival, clinical pregnancy rate, and then live birth rates. So they did this using something called a stepwise multivariate regression. And with that, they were able to look at which factors, after controlling for all of the confounding variables, actually contributed and to what degree did they contribute. So we're going to change now to table 1 just to kind of get a rough idea of this study, to kind of give you some ideas of the numbers. Have you got that up? Okay, so you can see that the total number of cycles was 9,970, and that was 11,936 blastocysts that they actually warmed. 9,306 were day 5 blastocysts, and 2,083 were the day 6 blastocysts. So pretty significant numbers there. This is a large study. You're going to get lots of robust data from this. Survival rate, very reassuring for all of you out there, 94.3 overall, which was 95.3 on day 5. And it does appear that there's a fairly significant decrease of about 6% when you go from a day 5 to a day 6. So this is an important factor for those of you that are freezing day 6 embryos. It's kind of critical to recognize your success rate, just even in the thaw, may not be as high as it would be if it's a day 5 embryo. So the next thing that they looked at was just kind of, that's important at least for us to discuss, is the percentages. So when you look at implantation rate per transferred embryo, overall it was 46%, which is really quite good. 50.6 in the day 5, but only 31.4 in the day 6s. So a big difference, and that p-value of less than 0.001 means that it is very, very statistically significant. When you look at clinical pregnancy rate, it's 50.6 versus 32.6. Ongoing pregnancy rate was 43.1 versus 25.5. So again, a huge difference there. And the live birth rate, 42.4 versus 25. So they are seeing a very significant decrement or decrease in these parameters when you look at this between day 5 and day 6 embryos. So one of the factors, obviously, is which day your embryo is frozen on. Did you freeze it on day 5 because it had already reached that stage of maturity, or did you freeze it on day 6? The rates are still quite good, but they're definitely lower with those day 6s. So we're going to go to table 2 now to kind of look at the survival parameters, just so you can get an idea of what factors were helpful in predicting the survival of your embryo from the thaw procedure. So we have table 2 up. Okay, so you can see on table 2 that the day of vitrification, meaning day 5 or day 6 for the day they froze your embryo, was important. If you froze on day 5 compared to day 6, you had a 56% increase in the chance that that embryo was going to survive. So they used day 6 as the reference and then said the day 5s have a much better chance of survival. So that's the first thing they looked at. Second thing they looked at was the degree that the blastocyst had expanded. And what they found was that if you reached the blastocyst stage, survival was 92% higher compared to a hatching blastocyst. Now this is kind of interesting because if your embryo is hatching, it's quite an advanced embryo. But I know my previous embryologist and my new one have both said if the embryo is hatching, you actually are potentially at much more risk when you freeze that embryo because they don't necessarily do as well. And this would appear to be supporting that data because the blastocyst that's still not hatching is going to do much better here, 92% versus the one that's hatching. When they looked at expanded blastocysts, there was a number that suggests that it's higher, but it's not statistically significant. And then when they looked at the fully hatched blastocyst, it's actually a huge decrease in success. So if you have embryos that have made it to that stage, you actually need to consider doing either earlier freezing so they don't let them go past the expanded stage, or you need to actually consider doing a fresh transfer so that you don't waste that embryo, because this is a 59% decrease if you have an expanded blastocyst. And this is from the multivariate model where they've already controlled for all of the possible confounding risk factors. The next thing that they looked at was the trophectoderm grade. So this is the grade of the portion of the embryo that's going to become your placenta. So some of you have undoubtedly heard that your embryo was a 3BB or a 3BC or a 4AA. So the 4-3 number is the size or expansion of the embryo. The first letter applies to the grading of the inner cell mass, and the second letter applies to the grading of the trophectoderm. So the higher the grade of the trophectoderm, the higher the chance that your embryo would survive. So with an A grade compared to a C grade, 51% increase. A B grade compared to a C grade, 46% increase. That doesn't mean that your C grade embryo won't survive. It just means that the higher grade embryos have a much better chance of survival than the lower grade embryos do. The rest of the things they looked at, including what the inner cell mass quality looked like, was not actually significant. So that was not an important factor. So then they looked at the live birth on table 4. So we're going to switch to table 4 now to analyze what the live birth stats are. So we looked at survival, what predicts live birth. So day 5 versus day 6 is almost double the live birth rate, a 96% increase. So almost 100% more chance that you would get pregnant if your embryo was frozen and then thawed from day 5. So that is really, really valuable data because it definitely tells us what we're looking at. Have you got that one?
Give me a sec.
That one is coming up. We'll pull it up for you shortly. But the numbers I'm reading to you are right here. So the referent is day 6, and if you're a day 5 embryo, you've got a 96% increase in the chances of live birth. When they looked at the degree of blastocyst expansion compared to a hatching blastocyst, the live birth rate, in contrast to what we just showed you at survival, is actually much higher. So a blastocyst has a 37% decrease. An expanding blastocyst has an 11% decrease. The referent that they used was the hatching blastocyst, and that one is sort of neutral. They did not look at the hatched blastocysts in this particular analysis. The other factor that they looked at, which turned out to be quite critical, is the trophectoderm grade. So when you look at the trophectoderm grade, they showed a 98% increase with the grade A's and a 57% increase with the grade B's compared to grade C. So the most important factor here, this actually was the most predictive element of your live birth. So there had more weight in terms of the statistical modeling than any of the other factors. The only other one was day 5 that was even close to this. So your trophectoderm score, that second letter in your 4AA or 4BC or whatever, is actually looking like it is one of the most important factors to predict your live birth success. When they analyzed the the inner cell mass to see how predictive that was, it actually was not predictive at all. So in this model, they showed no statistically significant increase. So can we actually use this data to predict your survival and live birth? We actually probably can. This is giving you very valuable studies and statistical values that will indicate to you what your chances of survival of your embryo are and what your chances of live birth are in reference to other categories. What's most important? The day that your embryos were vitrified, day 5 versus day 6, with day 5 being more important. The stage that the blastocyst has reached in terms of its expansion, and in terms of the trophectoderm score, what score you were assigned before they froze your embryo, because that's critical when it comes to whether your embryo will result in a live birth and also whether or not it'll survive. So thank you for joining us for this part of the show. Fact or fiction demonstrates it is a fact. You can predict, based on pre-freezing parameters, whether your embryo has a decent chance of survival and live birth without doing PGTA. So this will be up on our YouTube channel shortly. Make sure you like, comment, and subscribe. Push the subscribe button up there, which Tarek will post for you, I'm sure. And that'll be on the videos shortly. And watch all of our other videos. Every show is captured and placed on our YouTube channel, so you can catch them all there. So we're going to switch over now to the portion of the show where we answer questions. So we had one question that I'll take off the bat because I promised the writer that I would. And that was whether round cells make a difference when you're doing insemination or IVF in the sperm. So it does depend on what you mean by round cells. If you mean white blood cells, they can. White blood cells often signify infection, and if there is infection, there is a decreased chance of success. The company we talk about sometimes on the show called Fertility can actually look for viral infections inside the sperm. I haven't had anyone turn up positive yet, and we don't even know how to treat it if they do. But it's an interesting concept, and we know definitely that if there's white blood cells in the sperm, it can impact success rates. More importantly, it can interfere with your fertility naturally, and it frequently will cause men pain. So when we find those, we treat them with antibiotics, and then we reassess them to make sure the white blood cells have gone away. They don't always go away completely, but you can reduce them. If you mean round cells in terms of the sperm, if the sperm has more of an enlarged rounded head, that's frequently actually an immature sperm. And if you have immature sperm, it can very significantly impact your success rates. So it does depend on which round cells you're talking about. And certainly if there's blood, you should be seeing a physician. So yes, round cells can have an impact, but it depends on which cells you're talking about. And so hopefully that answers your question, and thank you for asking that.
How does the remote monitoring process for IVF work when patients live in the USA?
So patients can be monitored anywhere by any facility. We have patients, like for example, our egg donor program, which is probably one of the bigger ones around now in Canada, we actually monitor patients all over the country. We have patients being monitored in Vancouver. We have patients in Alberta. We have patients in Thunder Bay and Sault Ste. Marie. It doesn't really matter where they get monitored as long as they get monitored appropriately, and then they can fly into our program and we do the egg retrieval and the embryo creation here. So monitoring is not a difficult thing. As long as the place that you're getting them monitored at knows how to do what you want them to do, it's not particularly difficult.
My HCG levels have been good. 1,400 at the end of 4 weeks and 3,000 early 5 weeks, but I've had light pink spotting only when I wipe. Is that normal? Does HCG levels predict successful pregnancies?
HCG levels do not predict anything other than that you are currently pregnant, but they are poor predictors of anything. The only thing we know is that you should approximately rise by 60% every 48 hours to rule out the potential for an ectopic pregnancy. So a normal pregnancy in the first several weeks of the pregnancy will roughly double, but a minimum of 60% increase every 48 hours. But it's still not 100%. There are embryos that don't meet that criteria and still do well, and some that meet that criteria and don't do well. So it's not predictive. Spotting is never normal in pregnancy. Is it common? It can be. But is it normal? No. So you should be seeing your physician to make sure they know what's going on, and probably repeating your betas so that you know what's going on.
First question on Facebook. Hi, Dr. V. Does the flu or COVID virus hurt unborn baby?
No. So the flu virus does not cross the placenta, and neither does coronavirus, and neither of them hurt a baby physically. Certainly if you're very sick from the flu or coronavirus and you've developed pneumonia, or you're very ill in the hospital, you have respiratory difficulties, the chances that the baby will come out smaller or come out early are higher. And that's been shown definitely for the flu many times, and also for coronavirus as well.
Hello, Dr. Victory. My husband is taking HCG shots. He's breaking out with red itchy welts. Is this a common side effect?
No, and you should stop and get checked and find out what's wrong. That is not a common side effect. He's either allergic to a component of it or something else is going on, but you should stop that.
I did PGT. My results were 4AB, 3BB, 2BB, 3BB, 5BA, 4CD, 3AB, and 3AA. Which one are the best to transfer first and second?
The higher the number and the higher the grade, the better your embryo is going to do. And if they were frozen on day 5, you should take preference for the day 5s. So for example, a 4AA would be the best, and the one that was CD would be your worst. So you want to take the highest number with the highest letter grades on the earliest day.
That's a good question.
That is a good question, yeah. That's the whole topic tonight.
I didn't know that one, so that's why now I can reference that.
Tarek's starting to dabble in fertility advice to people because he listens in every week. Yeah, he's going to start his own show.
Using an egg donor and genetic screening reveals both my husband and donor are carriers of alpha thalassemia.
Thalassemia. Yeah.
Doing genetic counseling this week, would you recommend continuing to proceed with this donor?
No, because you have a 25% chance your child is going to have alpha thalassemia, and that is potentially fatal, and a lifelong history of needing to do blood transfusions. The only way around it is to spend an enormous amount of money to do something called PGT-M, which is like PGT for the chromosome karyotype, but they're actually looking for the thalassemia gene. And the problem with that is it's very expensive. You've now biopsied donor embryos, which we never recommend because it doesn't make any sense. And you're talking about a huge investment in terms of the whole procedure. And I would argue probably a reduction in success rates. So that is not a great idea. So I would strongly recommend that you consider not using that donor. Donors are all over the place, especially if you're in the US. Do not use that donor, select another donor. There is absolutely no reason why you would use that one unless there's something very unique about them.
I'm 5 weeks and slipped and fell on my back stomach. Was not impacted. I have a cut on my foot and minor back pain. I did spot a bit that night and then nothing after. Should I be worried?
So usually if you're not cramping or bleeding, it's not an issue. If you had some spotting, that's maybe a little bit of a concern. So you should get an ultrasound and follow your betas just to make sure everything's okay. It does take a fair bit of trauma to cause a pregnancy loss. But if you fell hard enough, sure, it's possible. So get checked out, make sure you have your betas checked and they can follow it, and then an early ultrasound just to make sure everything's okay. With the most sophisticated ultrasound technology, you can see a fetal pole with a heartbeat around 5 weeks, 5 days, 5 weeks, 6 days. So, you're almost at that stage. They can check it out for you. Yeah.
Are gas, cramps, pains normal in early pregnancy? The cramps aren't unbearable, but not comfortable and have woken me up a few times.
So any pain in pregnancy can be normal or abnormal, but must be taken seriously. So if you're having pain and it's early, what we always worry about is that it's an ectopic pregnancy. You cannot chalk it up to being gas. You have to go get checked out. So you need the betas, you need the early ultrasounds. Do not take chances, because if you have an ectopic pregnancy, it is a life-threatening condition if your tube ruptures, and that can happen with very short notice. So make sure you get checked out.
Can OHSS affect pregnancy?
Yeah, it can. So there's no question that patients that have OHSS in their fertility stim and then go on to get pregnant without actually waiting with a freeze-all actually have higher risks in the pregnancy. IUGR, preterm labor, preterm rupture of membranes. There's all sorts of complications. Preeclampsia is higher. So there are many factors that actually increase and risks that increase when you have the OHSS. Realistically, unless you're working with a center that truly does not know what they're doing, if you're getting OHSS from IVF, you should not be doing a fresh transfer. So it would be odd to see that these days. They got to have a damn good reason to want to transfer you if they are transferring you and you have OHSS. It just doesn't make sense, because if you are successful, and there are studies that say actually that during OHSS your success is lower, but even if you are successful, your chances of having a significant worsening of your OHSS are much, much higher if you do get pregnant. So you can actually have OHSS, get better briefly, and then get much worse once you're pregnant. So don't do it. That's a disaster setup. Just avoid getting pregnant, freeze everything, and then try again.
What are your thoughts on taking steroids for recurrent miscarriage during a pandemic?
Oh, that's an interesting question. That's a great question. Well, the steroids should not impact your immune system sufficiently if you're on a relatively low dose. And certainly if you're taking additional precautions or you've already been vaccinated, it's probably of minimal concern. Would I, take enough to suppress my immune system? No. But when we use steroids for helping patients with recurrent pregnancy loss, we're really using very, very low doses. It should not negatively impact your immune system, so it should be fine.
Do you encourage a second round of IVF if first one failed due to abnormal embryos during the PGS testing?
So that depends on a whole host of questions related to you. So your age, your health habits, your BMI, the sperm quality, the DNA fragmentation, how many other things you've tried before, what your family history is like, your finances. I mean, it goes on and on and on. The reality is, we have a video on this which shows that for patients that did poorly in a previous cycle, only 11% actually do poorly again. And that's in our YouTube channel with the Fact or Fiction, where we talked about what are your chances of failing in a second try. So, and I think it's got a big stop sign on it that says, when should I stop, or should I stop? So if you watch that video, it'll explain to you what the risks and benefits are. Not having genetically normal embryos in one cycle does not mean that you will for sure not have normal embryos in another cycle. But again, it depends on those factors. So for example, you're 45, you made 4 embryos, all 4 were normal. Should you try again? The likelihood is very, very high that even with another try, you're still going to have the majority be abnormal embryos. So it can take several tries at that age before you even get to just one genetically normal embryo. But that doesn't mean it won't happen. It just means you may need several tries. So that's a financial decision and a personal decision. But if you're 33 and you didn't have any normal ones, that would be very unusual. So aside from checking everything again first, like your genetics, I'd be very comfortable telling you to try again, because at a young age like that, you should for sure get some genetically normal embryos. And we use a protocol that, at least hypothetically, maximizes the number of genetically normal embryos in terms of the balance of recombinant to urinary FSH products we use when we're doing your stimulation. And there is a good study that shows that there's a specific ratio which is best. So that's what we use for our patients.
Hi, Dr. Victory. There's an exclamation mark, so it's like a real hi, Dr. Victory. Thank you so much for these videos. I'm 34 and preparing for my first FET.
Awesome.
I have 4 PGT embryos. I'm concerned because I don't see letrozole in my protocol. What do you recommend, and any supplements I should add in? Thank you.
So we get asked this every show. So we should just have a YouTube video on this. So our protocol is a down regulation with GnRH agonist, and then we give all our patients letrozole. And then we monitor their lining development and whether or not they produce a follicle, because even on the Lupron, some patients produce a follicle. So you got to be very careful with that. Then we either trigger if we need to, or we give them Cetrotide if their lining's not thick enough. We'll put them on estrogen to help thicken the lining if it's needed, but most of them don't need any estrogen. And then we go ahead and start the progesterone, both vaginal and progesterone in oil. And in the meantime, we have you on your prenatal vitamin, iron, vitamin D. You want to be on melatonin, and you want to be on as many sort of antioxidant-rich supplements and vitamins as you can be. So we also use the omega-3 fatty acids, more commonly referred to as the fish oils. We also use an antibiotic, and then we use a probiotic. So that all has actually come from doing this show, and our protocol right now is giving us over 80% success. So we're doing very, very well with our frozen embryo transfer program. And we're doing incredibly well, even just making the embryos. We have a 41-year-old that my embryologist just told me about today who had 8 eggs, 6 fertilized, and she froze 5 of them today and thinks the 6th one will be frozen tomorrow, all making it to blast. She keeps consistently getting 100% of the fertilized embryos or fertilized eggs to actually get to blastocyst stage, which is like unheard of. I mean, these are spectacular rates. I never had that before. So very, very good outcomes, mostly because she's incredible. And we've set up a top-notch lab with the best of everything. Anytime she says she needs something, I tell her make sure she gets the best available. So yeah, it's a lot having to do with how we set up the protocol, but you also have to have good embryos going into it. Sounds like you do. Just make sure that you are using all of those supplements and ask to have letrozole integrated into your protocol. Nothing wrong with that. You can always advocate for yourself. I hate the fact that patients have to, but I am a believer in telling patients that they should advocate for themselves because a lot of places aren't doing it for you, and so you have to do it for yourself. Yeah.
Hello, doctor. Smiley face. When should gonal F being started for an IUI, twin TTC?
Twin TTC? Okay, so first of all, don't try to conceive twins. It has nothing but complications. It's an 80% divorce rate. That's 80. And so we never recommend trying to conceive twins. Gonal F can be started at any point in an IUI cycle, depending on what you're trying to achieve. So most of the time we start it right at the beginning if you're just doing shots, or if you're combining your shots and your pills, we usually start 3 days of letrozole or Clomid and then start the Gonal F. That's what the majority of people do. You do have to be very careful. Gonal F is quite potent and it can produce a lot of eggs. If you produce too many eggs, you can turn into Octomom. So you got to be very cautious.
Can you please explain what neopogen is used in transfer protocol?
Neupogen?
Neupogen, of course.
Neupogen is used to improve the quality of your lining. And there are some studies that have shown that it is beneficial, although it is experimental still. There are no really good studies to demonstrate that Neupogen is helpful. There are also some studies that show that adding Neupogen to the embryo culture is helpful. And we actually carry that embryo culture for special cases. So it's very expensive, but if we need it, we need it. So we use it for the ones where we think we might. But overall, it's mainly experimental still. The data is not 100%, and we don't offer it here because I'm not a believer yet. It's very pricey for what it does, and I'm not convinced that the data is robust enough or convincing enough. But maybe that would be a good fact or fiction. So yeah, maybe we'll bring that up on another show.
Hi, Dr. Victory.
Good topic.
So many thanks for the amazing presentation.
Oh, no problem. Thank
What
you.
if the egg quality turns out poor, but you can get one embryo at day 5? Is it a good embryo or a PGTA is recommended?
No, I would probably generally recommend against doing PGTA on a single embryo. That's a lot of cost for just one embryo. I don't think that makes a ton of sense for anybody, so I definitely recommend sticking to just going ahead and arranging for a transfer. In that circumstance, I think it makes more sense to just let nature take its course. You're either going to get pregnant or you're not. And if you don't, overwhelmingly the likelihood is that the embryo was abnormal. So if you had bad egg quality, I'm very, very sorry. I know that is like the hardest thing to hear about. So my sincere sympathy goes out to you. I hate telling people that the egg quality was a concern. But one good embryo is all it takes, so you should still be very, very hopeful. And I've seen that more times than I can count. Which is why we do natural cycle IVF all the time, because we just get the one embryo. So don't lose faith, don't lose hope. There's lots of hope for you. And hopefully the community here watching will all keep you in their prayers, and we'll see how that little embryo does. But I would not recommend PGTA for just one.
I just had my first period in 15 years. Is there a chance I will ovulate, and should I be monitoring and testing using ovulation kits?
Is there a chance you'll ovulate? Yes. Should you use testing kits? Sure. My more important question is, why was it your first period in 15 years? So if that's because you were on birth control, that's fine. If you were not on birth control and you have not had a period in 15 years, you need to immediately see a doctor, because your risks of having a problem with the lining of your uterus are astronomical. So make sure you get seen and they figure that out for you.
How long does it take for FET after Lupron injection? I was given the injection on 21st day last month, and today is my day 1 period and awaiting next steps.
So we would start you normally on the 3rd day. So just make sure you contact, if you're with us, make sure you contact our center and tell them that today was your day 1, leave a message. And if you're with Sarah or Nima, just tell them and make sure that they get back to you. Yep.
You mentioned your egg donation program. Can you clarify? Is this a new service or did I just misunderstand?
We've been doing egg donation since we started. We don't have our own donors, but we have an amazing third-party program where we take patients that need egg donors or need surrogates, and we connect them with agencies that can find that for them. And then we get those donors and surrogates and use them as part of our program. Yeah, and we've got a huge program that's doing exceptionally well.
I know it takes sperm about 3 months to form.
Yeah.
How about the eggs that are used for IVF? Do they just develop the month before?
No. So as a woman, you are born with all the eggs you will ever have. So you don't form any new eggs. Many of them lie dormant and wait for the opportunity to kind of get into the race. And they wait until they're there. And then when they're in the opportunity to enter the race and see which one's going to become the lead egg, they jump on board and get into the race. So those ones kind of climb on board based on their willingness to do so. But all the other ones are lying dormant until the next round, and then another cohort kind of comes forward. So you're not making new eggs. It's just the ones that are in your ovary are kind of lining up to start the race. That's the best analogy for it.
Do you recommend Lupron injection for 6 months prior to an egg retrieval for someone who has stage 3 endometriosis? First IVF produced 2 eggs and failed implantation.
So they've done studies of Lupron for IVF patients prior to the egg retrieval, and it actually is not beneficial. Interestingly, Vizan was, and we've got a factor fiction on that from several months ago, but Lupron was not. So there's no data showing that Lupron prior to IVF is beneficial. However, there's good data to show that Lupron after your egg collection and embryo creation for 3 to 6 months with letrozole improves your success rates compared to not doing it. So I would definitely recommend doing that, but I would not recommend doing Lupron prior to your egg retrieval. The other thing to remember is, and this is just my opinion, but I believe it's grounded in pretty rock solid science, nobody with endometriosis should ever be getting a fresh transfer, because at the end of your cycle of your IVF, you're supercharging your endometriosis with the highest estrogen levels you can possibly have. Doing a fresh transfer in those circumstances makes absolutely no sense. Your immune system is in maximum overdrive. There's no way that it makes sense to do an embryo transfer, so don't do it then. Yeah.
Hold on, I just want to make sure that's the right one. Yeah. Hi, Dr. Victory. I'm so happy to be meeting you in April. Is it possible to still get a regular cycle, 22, 26-day average, even though according to progesterone levels tested in ovulation strips, I'm not ovulating, AMH of 2.9?
Okay, so first of all, your ovulation sticks are predicting your LH, not your progesterone. But just to be clear on that, you can get cycles, quote unquote, which are bleeds that are anovulatory, meaning not related to the growing and releasing of an egg. It typically happens when your lining is so thick it becomes unstable. The top part of it sheds, and so you're getting a bleed, and then it rebuilds and it bleeds. And it can be kind of rhythmic so that it's every 22 to 26 days, without you actually ovulating. If you're a 22-day cycle, you are ovulating very, very early. That would be day 8. So you actually should be making sure that you monitor very early on. It's possible you're just missing the timing of your ovulation, because if you're 22 to 26 days, you're ovulating between day 8 and 12. So maybe just move up the timing and see if that's what's the problem, where you're missing the ovulation.
At what percentage of sperm DNA fragmentation do you recommend Zymo?
Oh yeah,
My husband came back at 25%.
Yeah.
15 to 30% is borderline. Have poor egg quality. Our fertilization rate is, I think it's approximately 37% with ICSI across 7 egg retrievals.
Wow. Okay, so that's probably a lab problem. 37% with ICSI is terrible. So I would actually consider switching labs. Having said that, if you are dealing with DNA fragmentation that's 25%, that's definitely not good. That's considered higher DNA fragmentation. You're in the fair to poor category, and you definitely don't want to be in that category. So I would A, try to improve the sperm DNA fragmentation. B, you can use Zymo because it does reduce the DNA with the sperm fragmentation in them, although not eliminate, but it does reduce. And then lastly, I would make sure that they are doing everything possible to maximize the chances. Just the fact that you're saying you've done 7 egg retrievals, in my mind, is a lot. I mean, that doesn't make a lot of sense. Something needs to be done to change that, because that's an enormous number of IVF cycles. I have never done that for anybody. Nor would I, to be honest with you. That's unreasonable in my mind. So what can you do to improve the sperm DNA fragmentation? No smoking, no drinking, no drug use. If he's heavy, get his weight down. Tons and tons of vitamins to try and improve the sperm quality and remove some of the oxidative damage and stress. Cold therapy, so sit on frozen peas for 20 minutes a day. And then ejaculate every 2 days or so. And then finally, the tricks that we use are, number 1, do not let them spin the sperm in a centrifuge. Use Zymo or a swim up technique. 2, ejaculate twice, once first and then 3 hours later again. The 3-hour later sample has much reduced DNA fragmentation compared to the first sample. And then the other one is use Zymo. So Zymo actually has clinical data to support that it reduces DNA fragmentation. So we use it for that purpose all the time. So I would highly recommend that. That's a very good technique to use. Yeah, great question, by the way. Thank you for sharing. Try changing labs. You shouldn't be getting 37%. We don't have a single case where we've gotten 37% fertilization. Yeah.
If I've been pregnant and had a miscarriage, is there any reason to think I can't get pregnant again?
No. There is no reason to believe why you can't get pregnant again if you've been pregnant before and had a miscarriage. None at all. You should be able to get pregnant again. That doesn't mean that there isn't something wrong or that you don't need help, but there's no reason to believe you cannot get pregnant. No reason at all. You should be okay.
Can a trigger shot be a benefit if you had already ovulated and took shot after dose? It will help with implantation.
Yeah, so we have a fact or fiction on that from over a year ago now. And they did a study in Hamilton which showed that even if you're naturally ovulating or surging, taking the triggered shot at the time of the surge significantly improves your success rate. So that's an easy one to answer. Watch our YouTube video, it's on there.
Big question.
Big question, okay, drum roll.
What are your recommendations for wanting to transfer clinics? How many tries is too many for considering another clinic? And when do you know if you're at just $1 or if your clinic is doing all they can do?
Wow, that's a fantastic question. No one's ever asked us that, anything like that. Good question, okay.
I should have drum rolled it.
Yeah, I did the drum roll, I did it for you. Okay, so that's a great question. Okay, so let's take that one at a time. So how many tries is enough? Well, it really very much depends on what is being done for you. So if you go to a clinic where all they do is just keep throwing embryos in the same way over and over and over again, they're not willing to change anything, test anything, explore anything, do something different, that's time to change. For sure, that's time to change. And I would say with PGTA tested embryos, if you failed even 2, it's time to do investigations. With PGTA non-tested embryos, 2, maximum 3. So that's kind of my criteria within our own practice for where we tell patients, look, we need to do something to figure out what's going on because this isn't working with the traditional techniques we're using, so something else must be up and we must be able to explore other possibilities. What are those possibilities? Infections in your uterus or in your lining, endometriosis maybe, problems with your tubes, your immune system's overactive, thrombophilia. I mean, there's all sorts of things, but we start exploring the kind of fringe things that could be going on because even that study that we did review a long time ago from Richard Scott demonstrating that even if you have PGTA normal embryos, if you have 3 transfers with no adjunct therapy, you get a 95.2% success rate. But there is still that 4.8% that don't get pregnant. And obviously there is something wrong in those patients that needs to be addressed. So I believe in exploring that with our patients. So if you're not getting that from your center, then switch for sure. Or tell them, look, this is unreasonable. I love you guys, but I want you to do more for me. The second part of your question is, when do you know that you are being a dollar sign? Well, number one, if they're not willing to do anything more than what I just said, you're a dollar sign for sure. If they just keep telling you to come back and do more IVF, they're a dollar sign. If they're not giving you answers for what they think is going wrong, or they're not spending the time with you to explain it or to explore the options, you're a dollar sign. So I certainly don't want to besmirch or insult any programs out there. I'm not specifying any programs in particular, but I think that patients deserve answers, they deserve knowledge, they deserve education. And so when I'm talking to my patients about any part of their journey, I always kind of break down what's going on. I break down what the possible explanations are, and I break down what we can do for them moving forward. So for some people, it's really simple and straightforward. It's just, hey, try again because you only tried once, it didn't work. One try failure is very possible. For other people, it's, hey, you know what? I think we should hit the brakes and we should explore things before we do another transfer. And I'm actually your advocate many times where we have patients that say, no, I don't want to do any more testing. I just want another transfer. And I'm the one saying, wait a minute, I'm not confident it's going to work again. I don't like doing it if it's not going to work. So let's figure out what's going on. So I hope that answers your question. I mean, I think your comfort with your center has to be profound. You need to feel that your doctor cares for you, not about the dollar signs. So are they available for you? Can they answer your questions? Are they explaining things to you clearly? Are the things they're telling you rational? Do they even make sense? Would another specialist have the same opinion? And never hesitate to get a second opinion, because you might find that what somebody else is telling you is completely different, and that might explain where the problem is.
Ready?
Yeah, that was a great question. I'm really glad you asked that. Thank you for being brave enough to ask that question. Awesome. You do realize you're going to go blind that close to the
small computer. Sometimes. Oh, this is a good one. I think you're going to love this one.
All right.
What is the IVF success rate at VRC?
Again, it's impossible to answer those questions because it totally depends on all of the different factors. So if you're talking about donors, it's one thing. If you're talking about surrogates, it's another. If you're talking about autologous, it depends on the patient's age. I can tell you that right now we are averaging around 80% for our frozen embryo transfer success rates. So if you can get to the point where you have a frozen embryo and it's normal, or at least you're young enough that we didn't test you, you got a very, very high chance of getting pregnant. Very high. Yeah. And it's because of the magic of our team, led by our incredible Dr. Khosravi. She's amazing. I was just telling her tonight that I think she got a PhD in magic rather than embryology, because what she's doing I've never even heard of before. So we are very, very lucky to have her. We love her, and she's been amazing for us. And the rest of the team is incredible too. Everyone from front desk all the way to our incredible nurses, our nurse manager, Lisa, who everybody has come to love, our associate nurses. So we have Sarah and Nima and Kasha, and our Sarnia team as well with Carrie and Tara. And I think we have a new one joining, and hopefully Grace is coming back soon. So we have loads of people that are working with us who are amazing people doing amazing work. Most important of all, Mara, who holds the glue all together, and Wendy, and the whole entire rest of the team. I don't want to forget anybody, but everybody here is integral to what we do. We love them all, and we're all part of the team together. Everything we do together. Our social worker, our psychologist, our naturopath, our family doc that helps us. Every single member of the team is incredibly valuable. Yeah, we're a family, so we take care of yours.
Hi, Dr. V. Took me 2 rounds of IVF ICSI to get 1 euploid embryo at 34. Doc told me today my eggs are like 40-year-old since only 1 of 4 blasts were normal.
Wow.
Is this assessment valid? How to improve?
So it would depend on many things, but that's unusual for sure. It's very unusual. So I would need to know more about you, your AMH, your partner. What was the sperm quality like? Do either of you have a genetic disorder that no one tested for? You know, what was the protocol that they used for you? Were you on all the right meds, on the right vitamins? How long was your stim? Like, there's a lot of information that goes into that, but I can tell you that if you watch our embryo math video, we have a really good graph there. You can pull up embryo math, right? To pop it in. Tara's going to put the embryo math link right in there for you. So if you go to the embryo math video, there's a really good graph, and I believe it was an Australian study, but don't quote me on that part, where they showed the percentage of genetically normal embryos per age. And if you're 34, you should have at least half of your embryos be genetically normal. So if you were producing a reasonable number of eggs and only one of them came out to be normal, something is wrong somewhere. Now, it could be egg quality, it could be sperm quality, it could be genetics, but there's a glitch in there somewhere, and that needs to be addressed. I would definitely not recommend trying again until you've done testing to determine where the possible source of that is. So check out that embryo math video, because it's a great video. It's right there?
No, other side.
The other side? You're pointing in the other way, man.
Actually, I'm looking at it.
The embryo math video is somewhere roughly right around where my finger
If
is.
they just go to YouTube and type it.
And go into YouTube and type in embryo math. And it's a really good video. I did a PowerPoint presentation where I go basically from the A to the Z of how to get to what your chances are going to be. And we're very realistic in telling patients what to expect. So for people that are asking what their success rates are going to be and so on, this is very, very valuable information, because I broke it down so that you could actually understand the specific numbers of knowing what your chances would be moving through.
8:58. I'd like to do the...
You want to do the rapid?
Yeah.
All right, rapid fire. Is there anything else left on Facebook?
Yeah, there's a lot. But do 5 minutes there and see what you got.
5 minutes.
I don't know. Just go through.
Okay. I recently went in for an HSG. During the ultrasound, doc found a large cyst covering my, what he said, entire ovary and an endometrioma. I've already lost 1 ovary and tube. How do you determine if I need surgery to remove, or can I proceed with IVF? So if you have a large endometrioma, the problem with that is it's hard to actually get at the eggs without puncturing the endometrioma. And if you puncture the endometrioma, it can be a very high risk for infection, not to mention severe pain. So you are in a bit of a pickle. That is a tough case to deal with and a tough case to manage, because if they remove it, you likely will have very weakened ovaries for up to a year. And after that, they can stay weakened, but at the same time, keeping the endometrioma there also damages it. So That's a really tough case, dear, and I'm sorry you're suffering through that. That is something where you need a detailed discussion with your doctor to go over what the risks and benefits are for your specific case and whether or not they can access eggs from that ovary without having to puncture your endometrioma. In many cases, it is not possible. And if it's not possible, you do not want to puncture an endometrioma at egg aspiration or oocyte collection because your infection risk is very, very high. Is an ectopic pregnancy likely with IVF even after beta levels are good? If your beta levels are good, it's unlikely, but we always want to be cautious, so you always have to be vigilant. If you're having pain, spotting, go see your doctor. Are you in favor of continuing with ubiquinol once pregnant? Listen, there's ubiquinol in your body, so taking it or not taking it at that point makes no difference whatsoever. I'm about to do an embryo transfer. I'm worried about success rates due to my stress levels. How can I decrease my stress surrounding IVF? Fantastic question. Talk to Darcy, our social worker, or Brenda, our psychologist, or Dr. Jennifer Strong, our naturopath. Traditional Chinese medicine. We talked to Mary Wong last week on the show, so check that video out. Acupuncture can help. There are herbs that can help. Yoga can help. Meditation, prayer. And most of all, you know what? Reach out to your doctor because we're there to help set your mind at ease. We can reassure you as well, which often helps quite a bit. Exercise helps as well. Healthy diet. So don't hesitate. Anything that works for you to help calm you, use. Most of the guys out there would say sex. So if sex works for you, try sex. Thank you for answering my question regarding steroids. You're welcome. My pleasure. Thank you so much. Hi, Dr. Victory. Is it only the age of women or men's age that can impact embryo quality as well? I'm 35, husband 48. Once again, we have a YouTube video on that. So one of our Fact or Fiction shows looked at, does age of the male matter? And it definitely does. DNA frag is higher, miscarriage rates are higher, embryo quality is less. So your husband's age makes a difference. 48 still pretty young. So he's probably not in too much trouble, but it is a risk factor. At 4 weeks, my HCG levels were 1400 and doubled 2 days after. Awesome. I did have light linking spotting, I guess pink spotting, before and after the test. Do HCG levels predict a successful pregnancy? They don't really predict a successful pregnancy, but you sound like you're going to be okay. So continue monitoring. But if it's doubling from 1400, you're probably in good shape. But again, full disclaimer here for medical legal reasons especially, any spotting or pain is not normal in the first trimester, so go get evaluated because I don't want to be responsible for anybody saying that they had an ectopic and they didn't realize it because I said their beta was doubling and it was okay. It is not okay. If you have bleeding, spotting, pain, go get checked out. Make sure you go get checked out. Why would doctor add Clomid or Femera to egg freezing protocol? My AMH is 1.4 and I have 10 eggs and I'm 44 years old. Would you add Femera or Clomid to egg retrievals to get more eggs? Thanks. Okay, I'm confused. If you're talking about egg freezing protocol, I think you mean frozen embryo transfer. So you would never use Clomid. You'd only use letrozole, but it does improve it. If you're talking about egg collection, there are people that believe that letrozole and Clomid improve the responsiveness of your ovaries. It has been studied extensively. No one's been able to prove it's any better than any other technique. It's just one of many techniques for people that have weaker ovaries. Your AMH is actually reasonable if that's in nanograms per mil and with 10 eggs. So I'm not sure why they're doing it for you, because if you can make 10 eggs, that's more than enough. Or at least a good start. I shouldn't say more than enough. We have done 3 rounds of IVF and sadly no success. I am so sorry. That's terrible. We are ready to move forward with either egg donor or embryo adoption. What would be our biggest factors to consider for choosing one over another? Cost and the preference of your partner. I mean, if he's comfortable not being part of the biological picture, then there's much savings to be had in using donated embryos, and if you can access them, because it's often very difficult, then that is a fantastic way to go because there are literally thousands of embryos sitting there unused. If he very much wants to be biologically parenting, you don't really have the option. So then you have to kind of go with the donor, or at least that has to be a strong consideration. So either way is fine, but it's totally up to you guys. Yeah. Is it better to transfer 1 or 2 embryos with unexplained fertility? You know what, let me back up for a second first and just re-answer that last question. It also depends on why you didn't succeed. If your husband's sperm is terrible, you should go with the donor embryos, and or use your eggs with donor sperm. So it depends on who was kind of more responsible or what the biology of the situation was. 1 or 2 embryos with unexplained, it's always better to do 1 embryo. We're doing very, very few double embryo transfers, only when we receive them from another center where they were frozen as pairs. We've now had a couple of cases where we've received embryos from previous centers or other centers where they put 2 in 1 or 0 in 1, even though they said there was an embryo there, which is very confusing. You know, you got to be very careful. Hopefully your center is doing a good job. Not all centers do. Okay, whoops. I got a heart from someone I know. Thank you. I love you too. Volume is quite low and can't read anything you're popping up on Instagram Live. Can only see Doc. Sorry, Instagram sucks because it's this way, and Tarek is putting stuff as close as he can on the screen. So it won't fit unless I cover me, and then I'm off the screen. So we've tried to fix that, but unless you turn your Instagram sideways, it really just does not work. Okay, if I do my egg retrieval beginning of May, when would the FET likely be performed? The FET would likely be performed in July. Yeah. Bird Bash, what a great name. Do you suggest adding femera clone? No, you already asked that. Okay, I've already done that one. What is a normal ideal AMH? It depends on your age. So there is no normal ideal AMH, although generally speaking, the more it is towards the high side, the stronger your ovaries, the better you will do until it gets too high, in which case it's not great anymore. But it's age specific. So if you're using picomoles per liter, anything over 15 is wonderful. Anything over 10 is okay. Less than 5, you're in trouble. Less than 2, you're in a lot of trouble. So over 25 is great. Do you recommend eliminating specific foods with endometriosis diagnosis? Yes. So high cholesterol, high sugar, processed foods, anything with hormones in it, try and go pure organic. All of those things will help. Low meat, Mediterranean diet. Lots of veggies, lots of vitamin stuff. Fruits, no problem, thank you. Just wanted to let you know in case you didn't know. Thank you for all you do. Oh, we're like live. If there are 2 embryos frozen together and you only transfer 1, do they refreeze well? My embryologist and I had this discussion tonight. So freeze, thaw, refreeze, rethaw is definitely not recommended. However, we do it, and she says that if the embryo quality is good, it'll survive it just fine. If the embryo quality is not good, it's definitely not a good idea, guys. Okay, I think I'm on the last one. Is femera or clomid better to get more eggs? This patient is asking the same question 3 times. I actually answered your question, so I won't do that one again. You got one more from your side?
Yeah, 27 billion.
Tarek apparently has counted and read 27 billion questions. Okay, pick one. We'll go with one more.
Oh, pick one. Here we go.
The pressure's on. It's all you.
Got it.
Okay, the holy grail question. Here we go.
Their name ends in 007. That's why I picked it.
Oh, cool. All right.
PGS testing thoughts at 42. Otherwise, no underlying health issues. 2, MC1 was trisomy 21, the other chemical. Also, how many embryos to transfer with or without PGS?
Yeah. So at 42, you should definitely do it because about 70 to 75% of your embryos are going to be genetically not normal. So it is very important to do PGT testing. It's not PGS actually, it's PGTA. So it's very important to do that, especially in the history of having a miscarriage where you had trisomy 18 already. So that is very important in those patients, and we do strongly advise you to do that. So I would strongly recommend that you consider taking that leap. It would be well worth it for sure. If you choose to do it, you should only transfer one, if with a normal embryo, of course. If you choose not to do it at 42, 2 for sure would be reasonable. Some people would even argue 3. The reason being that with a 75% roughly rate of aneuploidy, not normal, even if you put in 2, there's a very good chance neither of them is normal. So it's actually not until you're putting in 3 or 4 where you're getting to the point where maybe one of them would be normal, and that's a maybe. So most people would advocate for 2, but genetically tested should always be 1. Call it quits. The questions just keep going on and on and on. We could probably stay here all night answering your questions, guys. So listen, thank you for joining us again. We love doing this show. It's an amazing opportunity to help. I love the questions, and I love the one about when to switch centers. That was probably one of the best questions we've been asked. I would love to know, and maybe throw up some likes, if you guys would like in one episode to just have an opportunity to ask questions about us or about me, not necessarily related to fertility. So someone suggested that, just instead of a fact or fiction, kind of a quiz Dr. Victory. So if that's something that's of interest, throw up some hearts and likes and thumbs up and all that fun stuff. And if that's something you want to do, great. And if not, then we will stick to the data and bring you scientific studies to look at next time too. But I'm always happy to chat. So if any of you ever have questions, don't hesitate. Feel free to reach out. And from all of us here at VRC, have a very safe week and a very nice night. Take care, guys. Bye.